This lesson is on iron deficiency anemia. Anemia is defined as a decrease in red blood cell mass. According to WHO, the cutoff point to define anemia in children include from 6 months to 5 years, hemoglobin level of less than 11, from 5 years to 11 years, hemoglobin level of less than 11.5, and from 12 to 14 years, hemoglobin level of 12, and from 50 to 19 years, for girls less than 12 and for boys less than 30 define anemia. Let's come to iron deficiency anemia specifically. Iron deficiency is a state in which there is insufficient iron to maintain the normal physiologic function of blood and the tissue, such as the brain and the muscles. The more severe stage of iron deficiency are associated with anemia or iron deficiency anemia. Iron deficiency anemia occurs when the hemoglobin concentration is below -2 standard deviation of the distribution mean for hemoglobin in otherwise normal population of the same gender and age, plus a measure of poor iron status. The most common age for the presentation of iron deficiency anemia is from 6 months to 2 years, and later during adolescence. This is due to increased iron requirement related to rapid growth. A full-term newborn infant contains about 0.5 gram of iron, compared to 5 gram of iron in adults. This change in quantity of iron from birth to adulthood means that an average of 1 milligram of iron must be absorbed each day during the first 15 years of life. Because less than 10% of dietary iron is usually absorbed, a dietary intake of up to 10 milligram of iron daily is necessary to maintain iron levels. Dietary iron absorption is primarily performed through enterocyte cells on the duodenum and the upper jejunum of the small intestine. When we see the etiology of iron deficiency anemia, most iron in neonates is in circulating hemoglobin. As you know, the relative hemoglobin concentration of newborn infant falls during the first 2 to 3 months of life, and during this time there is considerable iron recycle. These iron stores are sufficient for blood formation during the first 6 to 9 months of life in term infantis. So that is why in term infantis, anemia caused by inadequate dietary iron usually occurs at 9 to 24 months of age after this recycled iron is finished, and it's relatively uncommon thereafter. Delayed clamping of umbilical cord up to 3 minutes can improve iron status and reduce the risk of iron deficiency, whereas early clamping means less than 30 seconds puts the infant at risk for iron deficiency. So early clamping of umbilical cord is a risk factor for developing iron deficiency anemia. Worldwide, undernutrition or malnutrition is usually responsible for iron deficiency. When we see the specific cause of iron deficiency anemia in children, iron stores are depleted sooner in premature babies, low birth weight infants, or infants with perinatal blood loss, and they can develop iron deficiency anemia if not supplemented nutritionally. The second cause is blood loss. You should have to consider blood loss in any case of iron deficiency anemia. Source of blood loss can be menstrual blood loss, recurrent epistaxis, intravascular hemolysis. It might be due to occult bleeding, might be from peptic ulcer disease, Meckel's diverticulum, infantile polyposis, hemangioma, or IBD. Chronic iron deficiency anemia can be due to chronic intestinal blood loss induced by exposure to whole cow milk, especially during the first year of life. Infection with hookworms, Trichuris trichuria, and the Plasmodium often contribute to iron deficiency. Since iron is absorbed in the proximal duodenum, gastric bypass procedures or surgery or H. pylori infection might interfere with iron absorption. Approximately 2% of adolescent girls have iron deficiency anemia. This is largely as a result of their adolescent growth spurt and the menstrual blood loss. When we came to clinical manifestation of iron deficiency anemia, most children with iron deficiency anemia are asymptomatic. In mild to moderate iron deficiency anemia, hemoglobin from 6 to 10, there's a lot of compensatory mechanisms that are so effective that causes few symptoms of anemia aside from mild irritability to be noted. So majority of them are asymptomatic. Older individuals may report cold intolerance, fatigue, exercise-induced dyspnea, or decreased mental acuity. Pallor is the most recognized clinical signs of iron deficiency anemia, but it's not usually visible until the hemoglobin falls up to 7. It is most noted as a pallor of the palms, palmar crease, nail beds, and the conjunctiva. Most of the time, this palmar pallor appears so slow that the family might not detect because it changes slowly. When the hemoglobin levels falls to less than 5, irritability, anorexia, lethargy develop, and the systolic flow murmurs are often noted. If the hemoglobin continues to fall, tachycardia and high output cardiac failure can occur. When we summarize abnormalities in physical examination, in addition to pallor, on nail beds, koilonchia might be seen. This is due to retarded growth of nail plate. This is hollow nail, which is common in iron deficiency anemia. On tongue and the mouth, atrophic glossitis, angular chelosis, and stomatitis can appear. Atrophic gastritis or reduction in gastric secretion and the malabsorption can appear. The cause of these changes in iron deficiency is uncertain, but might be related to iron requirement of many enzymes present in epithelial and other cells. There are a lot of non-hematologic systemic effects of iron deficiency. So iron deficiency is not only hematologic problem. There are a lot of non-hematologic effects. Decreased brain iron stores may impair the activity of iron-dependent enzymes, which are necessary for the synthesis, function, and degradation of neurotransmitters such as dopamine, serotonin, and noradrenaline, which causes change in behavior and the lowering of developmental test scores or irreversible impaired neurocognitive function. After those things happen, even treating iron deficiency does not reverse them. So the child will be impaired neurocognitive functions throughout his life. Iron deficiency is associated with increased risk of seizure, especially febrile seizure, strokes, breath holding spells in children, and exacerbation of rest leg syndrome in adults. Pica, or the desire to ingest non-nutritive substance, and pagophagia, the desire to ingest ice, is common in iron deficiency anemia children. When we see the laboratory finding of iron deficiency anemia, on CBC, hemoglobin level, red blood cell, they are all decreased, and MCV and MCH is also decreased. Retic count, anisocytosis can be there, but platelet and the WBC count or leukocytes are normal. Platelets can sometimes increase. This is due to the effect of increased erythropoietin as a thrombopoietin that causes increased platelet number despite platelet program. On iron metabolism tests, serum iron concentration decreases, total iron binding capacity increases, saturation of transferrin decreases, serum ferritin level decreases. Serum ferritin level is the most important laboratory finding that tells us iron deficiency. Sideroblasts decrease and the serum transferrin receptor increases. When we see prevention of iron deficiency anemia, prevention is mainly by counseling. At birth, encourage breastfeeding exclusively for 4 to 6 months after birth and continue breastfeeding till 1 to 2 years of life. For infants who are not breastfed, recommend only iron fortified formula. For breastfed infants who were preterm or low birth weight, recommend 2 to 4 mg per kg per day of iron drops to a maximum of 50 mg per day and screen for anemia before 6 months of age. At 4 to 6 months, recommend starting iron fortified infant cereals. At 6 months, recommend 2 or more servings per day of iron fortified infant cereal to meet iron requirement. Recommend 1 feeding per day of foods rich in vitamin C, such as fruits and vegetables, to improve iron absorption. Vitamin C increases iron absorption. Around 9 months, begin introducing plain cured meats. Provide appropriate counseling for vegetarian families. Discourage introduction of cow milk before 1 year of age, and After 1 year, encourage iron-rich foods. When we came to treatment, the regular response of iron deficiency anemia to adequate amount of iron is a critical diagnostic and a therapeutic feature. Oral administration of simple ferrous salts provides inexpensive and effective therapy. The therapeutic dose should be calculated in terms of elemental iron. A daily total dose of 3 to 6 mg per kg of elemental iron is in 3 divided doses is adequate, with higher dose used in more severe cases. For example, ferrous sulfate is 20% elemental iron by weight and is ideally given between meals with juice, although this issue is usually not critical with a therapeutic dose. Calcium and the fiber may decrease the absorption of iron, but this can be overcome with co-administration of vitamin C. Tea is a significant inhibitor of iron absorption. Aside from unpleasant taste of iron, intolerance to oral iron is uncommon in young children. Iron therapy may increase the virulence of malaria and certain gram-negative bacteria, so we should not give iron when a patient is having malaria or having diarrhea or vomiting or any gram-negative bacteria infection. Iron overdose is associated with Yersinia infection also. In addition to iron therapy, dietary counseling is usually necessary. Excessive intake of milk, particularly cow milk, should be limited. Dietary iron should also be increased, and iron from heme source is 10 times more bioavailable than iron from non-heme source. So always we should have to counsel to increase iron from heme source. Heme iron include fish, poultry, pork, meat, and the like. Whereas less efficient iron is a non-heme source. It is absorbed by the body. Those are most of the time it's from vegetables and cereals. Iron deficiency in adolescent girls secondary to menorrhagia is treated with iron and menstrual control with hormone therapy. After treating iron, we should have to follow response to iron therapy in iron deficiency anemia. Within the first 24 hours, replacement of intracellular iron enzyme causes subjective improvement such as decreased irritability and increased appetite. And after 48 to 72 hours, reticulocytosis and up to 13 days, increase in hemoglobin is seen and the repletion of body stores are achieved within the first 3 months of iron therapy. The last one is what to do in the case of iron deficiency anemia that does not respond to oral intake. The common cause includes poor compliance to iron, wrong formulation, or continuing excessive milk intake. But if those things are normal, celiac disease should be considered and the serology requested. And alternative diagnosis include thalassemia minor and the rarely iron refractory iron deficiency anemia should be checked. Exclude GI blood loss such as Meckel's diverticulum, polyps, and the gastric ulcer by requesting stool for occult blood. This is all about iron deficiency anemia. Thank you for watching.